in Troy, Michigan. Tonight, we're going to show you how to easily grow your practice with effective extraction and grafting techniques for 2017. Before we get started, I wanted to just talk about a few administration items. First, as you think of questions during the presentation, type them in, please, and I will get to them as soon as I can at the end of the presentation. So don't wait until the end, type them in as you think of them, but I will definitely get to them at the end of the presentation. At the end of the program, we will also have a special offer from our sponsor, Golden Dental Solutions, and they will also outline the process to obtain your free CE for this evening. Most importantly, the program is recorded and you will be sent a replay link tomorrow. Achieving atraumatic extractions and socket preservation within your practice. I'd like for you to ask yourself these questions. Is your practice slow, or do you find that your schedule is not very full? Do you provide multiple services in one appointment? Do you offer dental implants within your practice? Are you performing surgical extractions in your office? And if so, are you grafting or doing some type of socket preservation? And lastly, do you offer oral, conscious sedation, or IV sedation within your practice? In today's economy, you need to offer comprehensive dentistry under roof. And that means you need to provide extractions, grafting, and implants. In fact, the aging population is living longer. According to the literature, age is directly related to every indicator of tooth loss. So as these baby boomers mature in age, they increase in number, and these are potential patients for your practice. Not only do we see the increased number of baby boomers, but we also see the increase in Mountain Dew, Red Bull, Jolt, Coca-Cola, a lot of these sugary drinks or acidic drinks that cause damage or wear to dentition. So not only do we see the mature audience with teeth that are no longer salvageable, but we are also introduced to a younger generation that also will require full mouth extractions. Well, if there's this increasing need, why have more general dentists not perform extractions? Well, they were either scared of not being able to get the tooth out entirely, or they were scared of damaging a blood vessel or a nerve, or even breaking a root tip. Sometimes they were scared to even be able to reflect a flap and get adequate access to a severely decayed tooth. If we look at the financial aspect, these dentists were not being reimbursed properly for the procedure, or felt they were getting reimbursed enough to even take these extractions into consideration for their practice. Also, extractions were taking too much time. If a patient was presenting for an emergency and the dental provider did not feel comfortable in taking these teeth out, or felt it would take too long, then it was something that would not be desirable for that practice. In addition to the dentist, the assistants would also have to set up a huge selection of instruments in the past, and this would take a long time to turn the room around. Today, my goal is to show you how to tap a growing market, how to implement atraumatic extractions and graft these areas effectively and efficiently, how to boost your overall productivity and market, but most importantly, we've joined this profession to be able to satisfy our patients' aesthetic and functional needs. In the past, when we speak to our patients about extractions, the biggest thing they can think about is fear. fear of past experiences. And it didn't even have to just be within our country, whether it was Europe or Asia or the Middle East. People just were not looking forward to having to have an extraction because they feared that it's going to be very painful, it's going to take a very long time. How many times have we heard from the patient, the last dentist had his knee in my chest and had to put so much force to remove the tooth? Well, we are going to talk about a different method this evening, but before we do, we need to look at the definition of an ideal tooth extraction. The ideal tooth extraction is the painless removal of the whole tooth or root with minimal trauma to the investing tissues so that the wound heals without compromise and no post-operative prosthetic problem is created. This is very important to keep in mind when doing extractions. So this evening, we will be talking about a new way of extracting teeth, a way that is atraumatic and a way that is simple. What makes more sense when we take a look at these two photos? We look at something with leverage and something without leverage. Obviously, the picture with using some type of leverage is the more ideal way of removing a nail in this scenario, and we'll see how this modified lever is utilized with the physics forceps from Golden Dental Solutions this evening. When we look at the physics forceps, it actually does work like a modified class 1 lever to move the tooth in the area of least resistance so that we preserve the soft tissue and the hard structures around this tooth when removing the tooth, so that when we place an implant later, we can do so without having to utilize major grafting. So let's take a look at the steps. Number 1, it's important to sever and separate the gingival tissue from the tooth. We can do this with a mucoperiosteal elevator or a curette. Step 2, it is ideal to place the beak of the physics forceps onto solid tooth structure. Thirdly, it's important to place the bumper as high up in the mucogingival fold in the vestibule so that we get an ideal leveraging of this tooth. Now, at this point, many people want to squeeze, but it's very imperative that you don't squeeze because you can break the bone. We are going to think of this as a modified lever. So we're going to rotate this tooth in the path of least resistance out of the socket, and then at that point, once that happens, we're going to release the enzymes from the PDL, and eventually, within 30 to 40 seconds, this tooth releases, and you can use gauze, you can use regular forceps, or you can use a tooth delivery system that the Golden Dental Solutions offer to finally remove the tooth from this socket. So if we take a look at the standard series of forceps, we have 4 instruments: the upper right, the upper left, the lower universal, and the upper anterior. For those second molars or hard to reach areas, we actually have the molar series, which helps us to get into the most posterior area of the mouth. And sometimes we see that we want to utilize physics forceps in pediatric situations, and there is actually a smaller miniature set for pediatric patients as well. Lastly, we also see the separators, which is a very new and important concept that we'll touch upon later in the evening. And if for some reason a root tip did break, we have the root pick series where you can see the neck of the root pick is solid and is not going to bend, and it actually has an elevator style handle so that you can actually put a little force to remove any retained root tips if they're broken beneath the gum line or beneath the bone line. So let's take a look at the first example, building the foundation for implants. This patient presented to my office with severe decay in her tooth. In fact, she had endodontic treatment a few years prior and was told by her endodontist to return to her general dentist to have this tooth cored and crowned. Unfortunately, since the patient was no longer in pain, she felt that she didn't have to have this tooth restored, and the cavit and the cotton pellet dissolved out, and the recurrent decay was established and continued further into the tooth to where it was no longer deemed restorable. So utilizing the physics forceps, we engage the beak of the forceps onto solid tooth structure, and we position the bumper as high up as possible within the mucogingival fold. Now you'll find in some patients this fold is very shallow, and in others it may be deep. In this particular case, you can see that it was quite shallow, yet the physics forceps was utilized, and in an efficient and effective manner, we were able to remove a first molar with no fractured roots and no breakage of the buccal plate. So you can see we were actually able to remove this tooth without having to section it. Here we can see that the extraction site is still intact. We identify to the patient that there is decay on the second molar behind this area, but since we were addressing her chief complaint, our first priority was to remove the tooth, which was the source of infection, curette the area entirely, and place grafting material, and cover that with a membrane so that at a later date, when the patient presented for an initial oral exam and complete set of x-rays, we in fact were able to restore the restoration in back of the edentulous portion, and then later place an implant into this area. So we actually were able to set the foundation for implant therapy. We see this quite often within our practice. In fact, I see it probably 3 to 4 times a week where a patient presents with either A, a vertical fracture, or B, a failing root canal to where the patient needs this tooth out. At those indications, we can easily extract the tooth atraumatically, graft the area, and build the foundation for implant placement. Let's take a look at another example. This patient presented. She had this tooth already endodontically treated and cored and crowned. However, on palpation and on percussion, this patient exhibited quite a bit of discomfort. In fact, when we probed around this tooth, all of a sudden the periodontal probe sunk down to about 10 millimeters, and we can clearly see obviously the fistula. So utilizing the physics forceps, we actually were going to remove this tooth. But I want you to think about this for a moment. When a patient comes into your office for an emergency, that is the best marketing opportunity for your practice. And I'll tell you why. Because number one, you look like the hero for getting them in as soon as possible and addressing their concerns. In fact, I've had patients that go to other dentists present to my practice for an emergency. I addressed their chief complaint and alleviated the pain and the source of infection for them. And when they compare this to previous traumatic experiences of having tooth removed, they said, wow, Dr. Nazarian, I had never experienced a tooth extraction like this. I would like for you to be my dentist in the future. And so at this position, we remove the tooth atraumatically, we graft the area, and we place the implant 4 to 5 months later, depending on the position of the tooth. If the tooth was an upper tooth, then usually we wait about 5 months, 4 to 5 months. If it's a lower, we usually wait about 3 to 4 months before we place an implant. Most importantly, we actually are saving the patient money because they didn't have to miss multiple days of work to go for a consultation at another office and then go back for the actual treatment. And again, we were able to alleviate their discomfort by removing the source of the infection. So if we return back to this example, only using wrist action, no force, no squeezing, we were actually able to remove this tooth, as you can see, and within 30 to 60 seconds, the tooth loosens, and then we remove it from the socket. If we take a closer look at this tooth, we want to try to identify exactly where that vertical fracture was to definitely see exactly what was causing this discomfort. And so by taking a curing light, we actually were able to identify the vertical fracture. So we irrigated the area, curetted it again, and then irrigated again, and placed grafting material. In this particular case, it was the Goldas particulate graft, and then we covered it with a membrane to get primary closure here and allow this area to heal. 4 to 5 months later, it was ready to go in and place an implant. And usually in the areas that I've grafted, I feel comfortable just using a tissue punch as compared to having to reflect a full flap for my patients when placing implant therapy. The beauty of this is there's very little trauma or discomfort, and here we're not impinging on the blood supply to that area by reflecting a flap. So keep that in mind. We want to keep things atraumatic. So what are the reasons for socket grafting? Let's take a look at a few. Number one, it prevents future bone loss and ridge resorption. We're able to support the adjacent teeth and implants. We can plan for future options such as implants or a fixed bridge. The fixed prosthesis, if there is no socket preservation, the pontic may start looking unaesthetic or be very large. But the most important factor or reason for socket grafting, I feel, is number 5. It's much easier to preserve. It's much easier to preserve now instead of trying to create later. And this is going to avoid additional surgeries later. So this was from Clinician's Report, Dr. Gordon Christensen, May 2010, Grafting Extraction Sites, Why, What, and How. So remember, number 5, it's much easier to preserve the day of the extraction after the tooth is removed as trying to create later. Let's take a look at this example. This was in fact a patient of mine, and the patient had a root canal core and crown on this tooth, and the crown and the post fractured off, and we found that this tooth would probably have, or this area would have, a better prognosis by placing an implant. So we informed the patient of all the risk benefits and alternatives, and we decided to remove this tooth. Well, we offered to graft this area for this patient, but the patient declined. She wasn't quite sure if she wanted, or wasn't quite sure if he wanted to have an implant placed at a later date or not. So all we did is extract the tooth. As you can see, by utilizing the physics forceps, we were able to atraumatically extract this tooth, and I reflect the flap so you can see that even with that thin buccal plate, we did not fracture that buccal aspect of the alveolar ridge. Okay? Now, 4 to 6 months later, when the patient presented back to our office, he decided that yes, in fact, he did want to have an implant placed. Well, I quickly informed him that now it's a little bit more complicated. It was much easier to preserve at the time of the extraction as compared to trying to create later. However, with some of the advanced techniques, we actually did reflect a flap, and we could measure and see exactly. We first start out with about 10 millimeters of width when the tooth was present, and when we extracted the tooth, we still had 10 millimeters of width present because we did not jeopardize the buccal plate when removing this tooth. But because socket preservation was not placed, because the patient declined to have it at the time of extraction, we can see that the ridge did collapse and resorb, and now we only have 5 millimeters of bone remaining to place an implant. Well, using osteotomes and advanced grafting procedures, I was able to place the implant by spreading the bone. As you can see, we increased the width of the ridge by spreading the bone. And eventually we went ahead and placed a 4x12 Oko Biomedical dental implant into the area. We further grafted around this implant, covered it with a membrane, and allowed it to heal so that when we returned 4 months later, we had a nice ridge that we can easily place the abutment into this implant, take an impression, and restore this implant confidently. So the lesson to learn from this is, again, it's more ideal to preserve as compared to try to go through these advanced techniques later to try and build the ridge, especially when we look at the width. So let's take a look. What are some of our options that are out there? There's a variety of different types of grafting material that are available to us today. The first is autogenous bone, where we take bone from the host from a different area than the surgical site. We also have xenografts, and some common examples are listed in the slide. And xenograft is usually from a different type of animal compared to humans. So usually we see bovine bone is the most commonly used xenograft available. Next, we have allografts. This is from cadaver bone, and this can be delivered in a variety of different ways. It could be in a gel, it could be in a putty, or it could be in a particulate graft. Lastly, we have synthetic bone, which are considered alloplasts. Some examples that are out there that are available and that we'll talk about a little bit today are Osteogen and Cerazorb. Today we are changing the standards. In fact, the standards are making us be more comprehensive and offer our patients the best that we possibly can. And it's important to be able to place some type of graft material in the socket following every extraction. This is rapidly approaching the standard of care status. It's very important for you to be able to offer this option to your patients. So keep this in mind when doing extractions within your practice. Let's take a look at a few other examples. Here we have a patient that presented to our practice with constant throbbing pain on tooth number 30. When we took a radiograph, we saw that the root canal was actually quite complete. However, there was a periapical lesion on the mesial roots. We saw that not only did this patient have a 10mm pocket at the mesial buccal line angle, but there was in fact a foul odor coming from this area. There was no mobility with the tooth yet, but we had definitely diagnosed that this tooth definitely had a vertical fracture. So our treatment plan was to extract the tooth, clean out the socket, place socket grafting material, and then seal this area with a membrane so that we could properly set the foundation for implant therapy. Utilizing the cow horn forceps from Golden Dental Solutions, we were actually able to take this tooth out atraumatically. And so utilizing the cow horn forceps from Golden Dental Solutions, what do we find that is unique from these instruments compared to other cow horn instruments? Well, the beak of this instrument is actually very sharp and it's longer. So this is the only instrument from Golden Dental Solutions that you actually do squeeze quite a bit. And as you squeeze, the beaks go into the furcation area. We're going to twist this forcep or this tooth mesially and then turn it distally. And then at that point go buccolingual and the tooth comes out quite easily. Here we have the GMX 17 and 23, and these are the cow horn series from Golden Dental Solutions. As you can see, we were able to atraumatically remove this tooth, and any granulation tissue that was remaining, we definitely wanted to clean out with a curette. So you never want to place grafting material into an area where we haven't cleaned out the socket completely of any granulation tissue. So that's very important, and then we'll rinse the area with surgical saline solution. Notice that the bone is still remaining in the furcation area. This is how atraumatic we were actually able to remove this tooth from the socket. So after we curetted the area, we placed grafting material. In this case, we used the Goldas DBM putty, as you can see. And then later, we were able to tuck the membrane at least 2 millimeters down the wall onto solid bone structure on either buccal and lingual aspects of this area. Here we can identify in the immediate radiograph how well this bone was packed, not condensed, but packed into the socket. Just 2 weeks postoperatively, we can see that the area is healing very well, and within 4 months, we'll be ready to place an implant into this area. So let's take a look at another example. Here we have a patient who presented with a tooth that was broken down at the gum line. When I present to my patients, some of you may even ask this at the end of the presentation, Dr. Nazarian, how is it that you get patients to accept to pay for the grafting in addition to the extraction? Well, what I like to use are these models that are also available from Golden Dental Solutions. And it's a rubber model where you can press or condense the socket to illustrate to the patient after the tooth is removed, if you do not place socket preservation, what you will find that's going to happen many times is that this ridge will collapse and you will have resorption to where you may not have enough width to place an implant. Again, it may not always happen, but it's much better to be predictable and place grafting material so that later, when you return 4 months later, you don't have to worry if there's going to be width or not. So I highly recommend placing grafting material at the time of extraction, So utilizing the physics forceps, you can see that we were able to atraumatically extract this tooth without having to section. And in the past, we would be using elevators, and you can see how severely decayed this was on the mesial and distal aspects. Utilizing the traditional methods, what we would find is that this tooth would break further and further down the socket to where it would be even more complicated to remove the tooth. So you can see we were able to atraumatically extract the tooth, this bifurcated tooth, and in this particular case, we use the Osteogen plug. What we like to do is remove that from the container and cut it and shape it like this bifurcated tooth and place this into the socket. Now, what is this made of? Well, we're all familiar with the Osteogen material, but it's carried in this collagen with bovine Achilles tendon is the collagen carrier. So it's almost like a dense collar plug, and it comes in a variety of different sizes. As you can see, we have the slim, which you could use for premolar with one root or anterior tooth, and then we have the large that can be sectioned into 3 portions or cut in half to place into the socket. Here are some of the benefits of the Osteogen plug, and this is available also from Golden Dental Solutions. But most importantly, if we take a look at the retail price of only $50 a plug, this is much lower than going with grafting and a membrane in those cases where the socket is entirely preserved because you utilize the physics forceps to atraumatically extract the tooth, and you can easily place this plug into the area. Now we want to pack this into the socket, but we don't want to condense it like an amalgam. The most important part of this to consider is no membrane is necessary when using the Osteogen material. So primary closure is not a necessity when using the Osteogen material if you're using it for socket preservation. If you have more than one wall missing, if let's say the buccal plate has broken off, then in that scenario, we would not use the osteogen. We would, in fact, use a membrane with a particulate graft. 4 months later, take a look at that ridge. It is a nice, healthy ridge, and there's absolutely no reason to have to reflect a flap. We can easily utilize a tissue punch, remove that plug, and place an implant of choice into the area. We can consider this a single-stage implant by placing an extended healing cap, allowing this area to heal for 3 to 4 months, and then remove this healing cap and take an impression. There's a variety of different materials out there. In this particular case, we use the impression material from Kettenbach. And here you can see we had a custom abutment fabricated and a full zirconia crown that was cemented onto this custom abutment. So we were, in fact, able to take this patient from A to Z within our general dentistry practice. And this is something for all of us as general dentists to be able to implement within our practice. Our specialists are not interested in a single unit like this. They would like to see the more complicated cases that are over our heads that we can refer to our specialists. So there's no reason why general dentists shouldn't be able to tackle these types of cases within their practice. And again, as I mentioned, there is a huge growing need for this because of the baby boomers increasing in size and number, as well as the younger generation that are drinking these highly sugar drinks and modified foods that are high in saturated sugars. Well, what about multiple extractions and grafting? Here we have a case where a patient actually had a bridge restoration, and this bridge restoration failed, it broke, and you can see that the pontic area was never grafted, and that had resorbed. So if our goal was to place implants, whether it was 2 or 3 implants with individual crowns, it was important to maintain that ridge by placing socket preservation and also increasing the width in the area where there was some resorption. If we look at the radiograph, we can see that the decay, especially in the molar, extended far below the gum line. So utilizing the physics forceps, we atraumatically extracted the teeth. We placed grafting material. In this case, it was the Goldas DBM putty with cortical chips. And then we covered this area with a membrane. In this case, it was a pericardium membrane from Golden Dental Solutions, so that later when this area healed, we would have enough bone to place 3 individual implants for this patient. How about if we want to temporize simultaneously at the time of extraction, grafting, and implant placement? This patient presented to my practice, and her lateral tooth had broken off at the gum line, as you can see. Upon taking a radiograph, we can see that this was a previously endodontically treated tooth, and we did, in fact, need to remove this in order to place an implant. It was no longer salvageable, as you can see, because of the recurrent decay. In fact, the canine also had recurrent decay underneath its previous existing restoration. So in this particular case, we utilized the VibraJet because the patient was somewhat apprehensive and did not want to feel the shot. And the way the VibraJet works is it sends, because it vibrates, it sends a bunch of impulses to the brain, and the brain cannot differentiate between this sensation and the pain. In other words, it's sort of like a shotgun effect to where it's sending so many impulses to the brain is confused and no longer feels the poke from the needle. Utilizing the physics forceps, we were able to atraumatically extract that root tip that was going on offset angle, and we were able to redirect and create a pilot hole so that we could place an implant of choice. In this particular case, I went with a very actively threaded implant. In this case, it was the Oko Biomedical, because I knew that I would be able to place an immediate abutment and place a temporary. So here you can see we've restored the canine with a composite restoration, and we've placed a solid abutment in the TSI implant so that the patient on the day of surgery is leaving our practice with a fixed temporary, not a flipper. We allow this area to heal. And 4 months later, we were able to take a regular crown and bridge impression. The laboratory fabricated a zirconia restoration for us, and we did in-office whitening. We do also perform orthodontics within our practice. We offer to do orthodontics for this patient for the other teeth, and the patient declined to have it. So we still were able to get a nice result, aesthetic result, within the limitations of not having to do orthodontics, as you can see. And notice how healthy the gum line is by atraumatically extracting the tooth and placing socket preservation, simultaneously placing the implant with a fixed restoration. Well, what about pediatric patients? Well, we talked about we can use this for pediatric patients. In fact, I have several orthodontists that refer to me because the patients have heard that I take pediatric teeth out or primary teeth out atraumatically, and we're no longer using the adjacent teeth to have to elevate. The last thing we want to see is somebody using an elevator and putting pressure on the adjacent permanent teeth that may not be fully developed. So here you can see we're utilizing the physics forceps with its class 1 modified lever, and we're extracting teeth. And you see these are all coming out very easily. And this is all under the direction of our orthodontist. They wanted all these teeth extracted. And as you can see, some of these teeth were very easy to extract, and some of them had some long roots. So the physics forceps works great in either case by not putting pressure on the adjacent teeth. Well, what about orthodontic patients? As I mentioned, I also do orthodontics within my practice. Here we have a patient who presented for short-term orthodontics. Our estimated time of treatment was 5 to 6 months. So by measuring the arch, we identified that the first premolar was the best to remove to get adequate spacing to straighten this patient's teeth. So on the day of banding, we actually extracted the first premolar, tooth number 12, utilizing the physics forceps atraumatically. We placed a little collar plug in the area. We didn't place grafting in that area because our goal was to go ahead and move the canine into that position. And within just 2 months, you can see how far the canine has already moved. And within a 5-month period, we were actually able to straighten this patient's teeth and restore his smile as well as his function. Let's take a look at a couple more examples. This patient presented to my practice, and she had several crowns placed on her maxillary dentition. Tooth number 8 and 9 had quite a bit of mobility as well as recurrent decay. So our treatment plan of choice was to extract these teeth, place grafting material to build the foundation for implant therapy, and then at a later date, place 2 implants with individual crowns. So again, because this patient was not sedated with IV sedation that I use for a lot of the larger cases within my practice, we utilize the VibraJet. And once the patient was anesthetized, we had our assistant take out the Golden Dental Solutions grafting kit. This grafting kit is great because no longer do your assistants have to go through the drawers looking for separate instruments. This was a well thought out kit from Golden Dental Solutions that allows us to have everything that's necessary to not only remove the tooth and graft it, but also shape the bone if necessary. So here you can see we're using the Orban knife to atraumatically sever the PDL from these 2 teeth. And we're going around each tooth circumferentially, And then we're using our curette to separate it further. Now at this point, we know from taking a scan that this patient has very thin buccal plate of bone, facial bone. In fact, she had a small fenestration in the number 8 area. So our goal was to not damage that buccal plate and to sever the PDL further and also separate the tooth by placing these in vertically into the PDL space and laterally expand the socket without further causing further damage or expansion to the point of breaking the buccal plate. So as you can see here, we've put the first tip, the pointed tip in, which we call the bayonet tip. And then in the other area, more towards the facial and lingual, we'll use the more flatter heads of the separators. So usually interproximally, we're using the bayonet, and then on the buccal and lingual aspects, we're using the flat ends of the separators. Once we've got some mobility and separation, we'll utilize the physics forceps to further extract the teeth from the sockets. Here you can see we've taken the teeth out. And because we know that there's a fenestration, I'm not going to place osteogen, but in fact, I am going to reflect a flap and place a membrane with grafting material. Before we do that, we will definitely curette the area and remove any type of granulation tissue from the sockets. And in this area, we can actually feel where that fenestration starts to go through. So at this point, we're going to further reflect the flap, utilizing our kit from Golden Dental Solutions. And here we're going to place our EpiGuide. And this is going to go 2 millimeters apical to the fenestration that was on the facial aspect of tooth number 8. We're going to place our DBM putty with the cortical chips from Golden Dental Solutions. Then cover this area with the membrane, suture it, and in fact, we were able to fabricate a flipper within our practice in a short amount of time so that the patient could leave the office with teeth until this area had a chance to heal. Our last case here illustrates multiple extraction within your practice. This patient presented to my practice for a consultation. As you can see, she's only biting canine to canine for the most part. So in order to restore this to the proper form and function, as well as aesthetics, our treatment plan was to extract all the remaining teeth in her mouth. So utilizing the physics forceps, we atraumatically extracted all her teeth, first by starting with the maxillary dentition. At this point, I prefer to reflect a flap and smooth the tines of bone. Here we have the aseptical handpiece where we're going to level the bone, just the tines of bone. We're not going to level it to where the upper denture will no longer be retentive, but just remove the sharp spots so that the patient doesn't complain of any sharp areas. We'll place our DBM putty from Golden Dental Solutions, cover this with a membrane and suture it. And in the lower arch, we'll do exactly the same. However, we all know that a lower denture is not as retentive as an upper. So I had recommended placing implants in the lower arch in the A and E position. And in this particular case, we use the Engage from Oko Biomedical because of its proprietary auger tip. We were able to place in the canine to premolar regions on either side with high torque values as well as Ostel values. And then we soft relined this denture with the Tokiyama soft reline. And here, 1 week later, we see the patient's happy with her immediate dentures. Once the area healed, we took reline impressions utilizing the Kettenbach impression material. And then we had the dentures fabricated from the laboratory. Here we see the full upper complete denture and the lower overdenture that would snap on to the implants using the Zest locator attachment. So, utilizing the physics forceps from Golden Dental Solutions, you too can not only increase the productivity for your practice and satisfy your patient's aesthetic and functional needs, but you can grow professionally by being able to be comprehensive for your patients within your practice. In today's economy, patients will put dental treatment off until it starts to hurt. By then, it will be too late, and these teeth will require extractions as you've seen in these examples. There are three types of people: those who make things happen, those who watch things happen, and those who wonder what happened. I want to thank you because tonight you're here listening to this presentation because the most successful people are in the first category, those who take this knowledge and apply it to their practices so that they may provide comprehensive dentistry for their patients. I want to thank you this evening. We're going to have Kurt Lawler from Golden Dental Solutions go over some questions for us, as well as go over some specials and promotions that you can take advantage of so that you may instill this type of treatment within your practice. Thank you.
All right, thanks, Ara. I appreciate it. And thanks everybody that was able to invest some time with us this evening. Let me just get my slides up here, and I'm going to quickly go over just a few basic things. I think Ara covered most of the information I was going to cover here, so I'll get to the Q&A session here pretty quickly. But I just want to clarify, a lot of people ask us, you know, what are the physics forceps and what are the sets? So as Ara explained, we have a standard series set of instruments. These are the instruments that if anybody has not tried the physics forceps or was thinking about evaluating them in your office, the standard series set will cover second molar to second molar on the upper and lowers. However, if a patient has limited access or a smaller mouth, you may not always get back to the second molar. So I don't want to mislead you there. You're definitely not going to get to a third molar, and sometimes you may not be able to access the second molar. But this set of 4 is absolutely going to give you the best leverage, and that's going to be the set that would make the most sense to evaluate. And I keep saying evaluate or try, because I don't know if I mentioned this, but with the Golden Dental Solutions, we believe in all of our products. They're all invented by dentists. They all understand what junk drawers are. And with the standard series set, we have 90-day trial periods on our products. So if anybody wanted to take a look at them or was thinking about evaluating the product, you're absolutely never stuck with it. If you don't like it, you don't like it. You've got 90 days to send it back for a full refund, which is a pretty favorable policy we've had here since 2007. So this molar series set, this is going to go further back into the mouth. This is going to be for erupted third molars and hard to reach second molars. This instrument, the twist is kind of like turning like a round doorknob in slow motion. You're going to lose a little bit of the leverage that you do get with the standard series set, but this is going to allow you to go further back into the mouth to be able to access teeth that maybe you can't access with the standard series set. The one other nice benefit of this set of instrumentation is, as you saw with the standard series, the bumper is always placed on the buccal side of the mouth. Here, with the molar series, depending on if the root is angled a certain way, or maybe you can't get a good purchase point in the lingual aspect of the tooth, this set will allow you to place the bumper on the buccal or on the palatal or the lingual aspect of the tooth. So the bumper on this one can go on either side of the tooth, and you can either be rotating lingually or buccally. So this is just a set of 2 instruments, complements the standard series set. So hopefully that clarified a couple questions I've seen come through on what are the sets, and how many are there. So in total, there are 6 physics forceps. These are the separators. These are new for us. We've had these, I think a little over 6 months. So some dentists have asked us, do you need to elevate in advance with the physics forceps? And generally, we've always said no. The physics forceps is the elevator. You do not need to elevate in advance. But for doctors like Dr. Nazarian, who place a lot of implants, you want to make sure you're going to preserve the tissue, prevent any type of tearing. This is a good set of instrumentation that Ara helped us develop and clinically test, where it's going to allow you to start the extraction process. So you're still going to use the physics forceps, but this is a good instrument if you want to start to sever the PDL, or if you just want to separate the tissue. This is an instrument that we've had a lot of good feedback on over the last 6 months from our existing customers that have the physics forceps. This is a great simplified set of 3 that's a nice add-on to your physics forceps. Root tip picks. These are the ones that Dr. Golden's used for 40 plus years, more or less. We hear in our extraction course that sometimes the width of the beaks or the pick aspect is too thin, or the steel may be flimsy or bend, and so we went ahead and started producing these right around the time as the other separators, about 6 months ago. And we've had good feedback on these. They're blue titanium tipped. They're real strong. These are the ones that Dr. Golden, the inventor of the physics forceps, has been using for, like I said, 40 plus years. These are really good root tip picks, and these are what you're going to want to use if you have a patient that presents with a root tip, or if you have the unfortunate experience of leaving a root tip behind. So I just want to mention one more thing. For regenerative materials, we do have a full line of materials of allografts. One simple product is going to be the osteogen plugs that we discussed a little bit this evening. I would encourage anybody to take a look at our bone materials. If anybody's not aware that we do have graft materials, I think you'll find that our pricing is actually extremely competitive. I think it's actually some of the lowest priced materials that are on the market. And so with the osteogen plugs, this is it's a discount that I'll provide here in a moment. It's $42 a bullet with no membrane. So as Ara explained, if you have a socket where all your walls are intact, this is really a great product that anybody can use, regardless of grafting experience. If you're looking to get into grafting, this is a really great way to start. And a lot of our doctors are having really good success with the osteogen plug and the type of bone that's being replaced by the body where the osteogen plug is placed. We're having good feedback for people that are drilling into the space for implants. And again, great feedback. Super simple, just place it in the socket, and it's absolutely not just a collagen plug. It is a bone graft. So at $42 a bullet, you really can't go wrong with that to start grafting or offering this service to your patients in your office, regardless of your grafting experience. One thing I'll mention is if anybody doesn't have a good graft kit, this is the one that we have. It's a simplified kit that is used for our Amplify CE instructors, which would be Ara Nazarian and Tim Kaczynski. It's a simple kit. It's going to have your Curad bone file, Orban knife, basic scissors, suture holder. And I think that if anybody's looking for something that's cost effective, wants to keep the kit together all in one place, we'd encourage you to take a look at that. Last thing I'll mention before I do go through the questions, we do have quite a few of them here, is we have through Golden Dental Solutions, our continuing education component of our company is called Amplify. And we really do have a very unique live patient CE program with our instructors, which would be our presenter this evening, Ara Nazarian, Dr. Tim Kaczynski, and Dr. Richard Golden. These really are great programs if anybody wants to learn more about a hands-on live patient program, we offer a program called AMP1, which is just extractions and then very simple socket preservation, which is more or less the osteogen plugs. And then we have an AMP2 program, which is a 2-day program that's actually focused on extractions and more advanced grafting. And the nice thing about the program is that all of our attendees do their own procedures. We provide all the patients, all the instruments, all the materials. You really just need to show up. And we have one coming up this weekend. This one's sold out with 25 dentists. And we'll see anywhere from 80 to 90 patients and take out several hundred teeth during the program by the attendees. So it's a great learning experience. If anybody is interested in something like that, I would encourage you to take a look at the amplifydental.com website. There's a lot of great information on there, and I'd be more than happy to respond to any questions or information that anybody would like on these programs. Here's a picture of the clinic floor. It's at the University of Detroit Mercy Dental School. There's plenty of chairs, like I said, plenty of materials, products, and we got a lot of patients here in Detroit that are in need of dental care, so it's a great experience for everybody. So here's, I guess, what some of you are probably waiting for. We offer a 15% discount for investing your time this evening with us. That's also applicable to our CE program, so you can actually use it on our CE course tuition fees. The promo code is going to be WEB15, so it's just WEB15, and that would be good for anything we have. So if you're interested in maybe thinking about the physics forceps, maybe want to try the osteogen plugs or any of our other grafting materials, that's a great way to try it, and you get rewarded for investing your time with us this evening to get the 15% discount. So we do these 15% discounts, which are actually better than the trade show discounts. We do them for a short period of time. The discounts are valid through the end of the day tomorrow. So we do a quick 24-hour discounts, but a 15% discount is a pretty good discount on our pricing. And again, it's better than we normally provide even at the trade shows. So if anybody wants to take a look, physicsforceps.com. Again, WEB15 is the promotional code, which works giving us a call here in the office or online. All right, so let me, I'll start to get to some of the questions here. We've got a pretty large handful of these questions for Dr. Nazarian to answer. I guess the first one, Ara, is do you always graft following an extraction? And then I guess I'll add on another question to that question. So it says, do you always graft following an extraction? And then if you could please elaborate or maybe provide some information on the typical fees you charge for an extract and graft, and then do you generally change your fees based on the type of product you're using?
So what I recommend is bundling that fee. So whether you're using the osteogen or using a grafting material with a membrane, find a number that's comfortable, because the last thing you want is to nickel and dime your patients. If, let's say, you are going to tell them you're going to charge them for just an osteogen and it's a lower fee, and then all of a sudden, unfortunately, let's say you break the buccal plate and now you have to use a membrane and particulate graft, all of a sudden your costs have gone up, and you say, well, now your grafting cost is a different cost. So my goal is to have a bundled fee. My grafting fee for a socket is $495, and to remove the tooth, it's $267. So within under a half hour, you're providing not only a great benefit to your patients by doing all the services under one roof, but also nice productivity for your practice. And
okay,
yes,
perfect.
excuse me. And yes, I would say almost always I will place socket preservation at the time of extraction unless the patient declines to have it done, or the infection is that bad that I would prefer to come back at a later date and do it. Usually it's going to be about 2 weeks later if the site is that infected that I don't want to place grafting material.
Okay, perfect. For the osteogen, I guess I'll combine two questions again. Can you explain, I guess, the suture technique for the osteogen, and then the second component of that is what type of sutures do you generally prefer when you're doing your grafting?
So when I'm usually doing an individual case, I like to prefer, or I prefer to use silk because it's inexpensive and when you tie a knot, it stays in place. However, it's imperative to remove the silk sutures within 7 to 10 days from the time of the extraction. Otherwise, you get a lot of debris and food that accumulates on the silk sutures as well as bacteria, and then it can cause an inflammatory response. So if you're going to use silk in those individual extraction cases, then make sure they're removed within 7 to 10 days. If you're using any type of sutures for the osteogen procedure, usually I'm creating an X over the extraction site to make sure that that osteogen plug is not going to come out. One of the things to note is that the consistency of the osteogen plug is not like a collar plug. It doesn't get all slimy when it gets wet with the blood and become flimsy. It's actually pretty stiff. And once you pack it in, you still want to suture over it, but it's not coming out of the socket like you would imagine a collar plug. It's a much denser material and it's a much better consistency. Again, it is not a collar plug, it is a bone grafting substitute.
All right, perfect. And we have quite a few questions on the separators. Can you explain again, I guess, just the use or when you would use them? We have some users that are saying they've used the forceps for years, the physics forceps that is, and historically they have never really elevated in advance. And I guess can you just elaborate or explain the benefits of maybe using the separators and what specific cases those could add value to the doctors that are currently using the physics forceps?
Right. So utilizing the physics forceps in the way that they're intended to be used, you usually do not have to use any type of separator or elevator. However, this is a totally new concept for a lot of us that have been used to elevating or severing the PDL or separating the tooth from the socket of some sort. So for those individuals that don't have the patience or that have found that when they've utilized the physics forceps, they were breaking buccal plates or they weren't able to get the teeth out consistently in the manner that they wanted to, then I definitely recommend using the separators. The separators, as we mentioned, the bayonet tip, which is the sharper tip, helps to get into the interproximal areas where there's an area that's curved inward and another one that's curved outward that are used either on the buccal or lingual aspect. And this is just another adjunct to the physics forceps for those doctors who may already have the forceps and said, well, I still want to loosen the tooth or elevate the tooth of some sort before I use the physics forceps. What I have found is, especially in those cases, let's say you have a very long canine and you see that the buccal plate is very thin. Even with traditional methods, you may have even cracked the buccal plate. My goal is to be very atraumatic and allow the tooth to loosen as much as possible before I extract it so that we can preserve that buccal plate of bone, because I'm always looking at restoring it eventually with an implant, abutment, and crown.
Okay, perfect. No, that makes sense. A couple questions on the Epi guide. I guess if you wouldn't mind just explaining, I guess let me try to combine the questions. Some people were asking again if it's resorbable or non-resorbable. Do you have to remove it? And then there were some questions on, I guess I can answer this one. It's an 18 by 30 size, so it's a big sheet. Some people asked if you can cut it. So I guess if you or maybe if you could elaborate, I know it's a resorbable membrane, but I guess if you wanted to elaborate maybe on the.
Yeah, so EpiGuide is a resorbable membrane that usually takes 6 to 8 weeks to resorb in most individuals, and it's synthetic. So no longer do you have to worry about that funny smell that we used to find with pericardium. It is side specific, so there's one side that goes towards the bone, and there's another side that goes towards the gum tissue. And what you'll find is you don't necessarily have to have primary closure. You take a large molar out, there's no way that you're going to get the gum tissue to close up over that socket. So the EpiGuide works great because number one, it's synthetic. It's got multiple layers to it that allows it to resorb long term in 6 to 8 weeks, and it doesn't have any smell to it, and it doesn't resorb that quickly like a Colatape or anything like that. But unlike some of the synthetic or other membranes that are available, you do not have to remove it from the area 4 to 6 weeks later. It will resorb on its own. It's the best of both worlds, quite honestly, because it's synthetic, so it's not as expensive as a pericardium, and you don't need to have primary closure. And most importantly, you're not going to get that funny smell from the area if there is some of the membrane that's exposed, like you find with pericardium.
Okay, perfect. Sectioning, I guess, can you explain the sectioning component with the physics forceps? Do you section upper or lower molars?
Right, so usually in the upper arch, because we're looking at D3 or D4 type of recommending sectioning, as you saw in a lot of the examples that were illustrated in this evening's seminar. However, in the lower arch, if I can't get the cow horns of the Golden Dental Solutions forcep furcation area, then we'll routinely section right in the furcation area and treat each root as an individual tooth utilizing the lower universal forceps.
Okay, perfect. One quick question on, can you just explain the purchase point? What type of burr do you typically use? How far do you go down? Is it at the expense of the tooth, or you're removing bone? How is the purchase point made for the beak?
So first of all, you want a purchase point on solid tooth. So if there's solid tooth that's not below the gum line that you're able to engage the beak onto, then you don't have to create a separate purchase point unless it's a very convex tooth, and you may want to flatten it so that the beak rests on it with the most surface area as possible. In those cases where the tooth is broken down to the gum line or slightly below the gum line, what I like to use is a 557 tapered burr in a friction grip with an extra long shank. So it's the surgical length in the friction grip. And what I like to do is go in between the bone and the tooth, but you're going more towards the expense of the tooth as compared to the bone in order to get the beak into that area. The beak is very thin, so you're able to get that in by trenching that little area out and creating a nice solid purchase point for the beak of the forceps to engage.
Okay, this is a newer question that just came in, but it's kind of related to that, I believe. It says, have you ever had to trough to access enough coronal exposure to engage the physics forceps?
So the only time that I'm going to trough around the root tip is for some reason that it's so broken down, either due to decay or fracture down the crest of the bone, that my forceps can't engage that far deep, and I don't want to trench that much, that I would actually trench around it enough to get the root picks that was illustrated on your special and pop the root tips out. So yes, there will be some cases where if it's broken, if you have a root tip, only a third of the root tip remaining, you're not going to be able to get the beak into that socket to get the root tip out. At that point, you would trench enough around that root tip to get the root picks in and then elevate that tooth out, or the roots out.
Okay, perfect. That makes sense. We have a couple questions about like infection of the sockets and grafting, and I guess this one specifically says, how do you decide when a periapical abscess is too large that a bone graft would likely not be successful anymore?
So if somebody comes in and their face is swollen and they have a cellulitis and there's oozing pus from the area, those are the cases where we don't want to place grafting at the same time of the extraction. We wait 2 weeks later and go back in and place grafting material. However, if you have a patient that has a periapical radiolucency, that may be a cyst of some sort, we want to definitely clean the area out with a curette. It's not uncommon for me to also go in and decorticate the bone to initiate some more bleeding in the area or remove any other granulation tissue in the area. So I would say if there's active infection where there's pus and there's a huge cellulitis, in those cases, the key is to remove the source of infection, which is the tooth, allow the area to heal a couple weeks before you place grafting.
Okay, perfect. I'll take these next two. There's a couple questions on the CE programs about AMP1, AMP2. Can I work on the live patients? Do I need a license? The answer is absolutely you can work on the patients. You just need to be a licensed U.S. or Canadian dentist. It's a teaching facility, so there is no licensing restrictions for out-of-state dentists from outside of Michigan. Somebody asked if they have to take AMP1 before AMP2. The answer to that is no, and of course not. I mean, if you would like to utilize the physics forceps or some of the other techniques, the separators or cow horns, and you're still going to obviously use those products in our AMP2 program, but if you're already doing grafting, or if you're already doing extractions and want to maybe learn some new techniques, or just want to get a little bit more comfortable with extractions, but you're more interested in the grafting component, then absolutely, you could just come to AMP2 first. We'd love to have you. AMP1 is more for people that they solely want to focus on extractions and a really simple graft, which is the osteogen. But AMP1 is not a prereq for AMP2 by any means. We definitely have people that come to AMP2 that just want to focus more on the grafting component, but also try a couple new extraction techniques. All right, I'm trying to respect everybody's time here. I guess I'll get to maybe just a couple more questions here. If there's any questions we didn't answer, we'll try to respond via email. I guess, Ara, can you just explain real quick the maybe what's a good analogy or way to explain the amount of pressure that you actually have to apply to your wrist to get that arc of rotation? Or, I mean, would people be surprised at how much, I guess, pressure you really need to apply? And I guess, can you go over again, I guess, the holding period and how you sort of wait and how that works?
Yeah, I would say the key to remember is that this is a modified one lever, and what we tell our docs at the residencies and the courses, the hands-on courses, is number one, to retrain your mind to not squeeze the forceps. Everybody wants to squeeze, and if you squeeze, you will break the bone or you'll break a tooth or something. What you want to do is pivot or rotate the forceps around that bumper. So in other words, you're using the beak to almost lift the tooth from the socket, rotating it around the bumper. The force that you use, in some cases, it depends on the root. If you have a tooth that has 3 roots, obviously you're going to put a little bit more force than what you would expect from a single rooted tooth. However, the force is not what you would expect with the traditional methods of extracting teeth, because you're using a lever. So it would be hard to explain. I would invite those doctors that are interested to come to the hands-on courses at the University of Detroit that are offered through Golden Dental Solutions, because I could explain it for 2 hours and you won't really understand it until you actually feel what type of force or pressure that you have to do. But when we say force, it is minimal force as compared to traditional methods.
Okay. All right. There's a few more questions, but I'm going to I think we wanted to wrap this up here by 9:15, so we'll respond to any questions that we have not got to through email. And I wanted to thank Dr. Nazarian for his time this evening in presenting the cases, and I'd like to thank everybody that invested your time with us this evening. We do appreciate it. We're always available here at Golden Dental for any follow-up questions, or if you have any questions on our products, we're more than happy to help you out. Just give us a call or send us an email. And I hope everybody enjoyed the presentation this evening. And maybe we'll see you in Detroit for one of our programs, or otherwise keep your eyes open for one of our upcoming webinars in early 2017. Happy holidays, everybody, and Happy New Year in advance. Thanks, everybody.
Happy holidays. Thank you, and good night.